Hi students, you're listening to Chapter 22, Management of Patients with Upper Respiratory Tract Disorders. So by the end of this chapter, you should be able to describe nursing management of patients with an upper airway disorder, compare and contrast the upper respiratory tract infections according to their cause, their incidence, their clinical manifestations, the management of the infection, and the significance of preventative health care. You should also be able to use the nursing process as a framework for care of your patient with an upper airway infection and describe nursing management for a patient with epistasis. Okay, so we have different types of respiratory infections and we'll go over them individually, but they are rhinitis, rhinosinusitis, pharyngitis, tonsillitis, adenoiditis, peritonsillar abscesses, and laryngitis. Most of them are viral, and if you have an older adult, you do need to consider that they have probably a compromised or lower immune system, and so upper respiratory infections, even if they are viral, can be more serious, and they can lead, if they have a chronic respiratory condition, to an exacerbation. They can also turn from just a normal upper respiratory infection, or what we would call a cold, to a more serious infection, secondary infection, which could lead to sepsis if it's not treated. So rhinitis is a group of disorders characterized by inflammation and irritation of the mucous membranes of the nose. So that would be the area here, whereas rhinosinusitis is actually in the sinus cavities. So it's the place that makes it a little bit different. Rhinitis can contribute to sinus, ear, and sleep problems, as well as learning disorders. And that is because if you have problems with the ears and you're not hearing, then you're going to have a harder time paying attention and learning in school. Rhinitis can be acute. It can also be chronic. It can be caused by allergies. It can also be caused by virus or bacteria or fungus, some kind of an infection. Signs and symptoms include excessive nasal drainage, or what we call a runny nose, nasal congestion. The patient can be sneezing. They can have itchy nose. The roof of their mouth can itch, and then their throat, eyes, and ears. They can also complain of itching. They might complain of a headache as well. Treatment, give antihistamines because that's going to help stop the histamine released, which causes the runny nose, stops the allergic reaction, inflammatory response within the body. They can get corticosteroid nasal spray, which will also help with the inflammation. And then obviously whatever is causing it, try to remove the irritants. As far as nursing implications, they should not be smoking. They shouldn't be smoking anyway, but that definitely can cause irritations. They need to be taught how to figure out what the triggers and irritants are so that they can be avoided. They need to be taught proper hand hygiene in case it's an infection that's viral or bacterial that could have been prevented. Coughing and sneezing protocol, so they should be coughing and sneezing into their elbow or their arm. And the nurse also needs to teach proper use of the medications as well as the purpose and side effects, and when they need to call their doctor if they have any kind of adverse reactions. If the infection is viral, encourage fluids. They can do warm saltwater gargles. They can take anti-inflammatories to help with the pain. Antihistamines, expectorants. Basically, you're just treating the symptoms. If it is bacterial, they need to be taught to take the antibiotic as prescribed until it's completely gone. Hey, sorry, my cat's playing with the headset that I have on. Rhinosinusitis is an inflammation of the parasinus cavities as well as the nasal cavity. It generally will follow another respiratory infection or cold, and that's because you have inflammation here. If I can get my pen to work, you have inflammation in here, and because of this inflammation and this all being inflamed, your sinus cavities here cannot drain, and so that fluid sits. It's nice, warm, and dark, and is a great place for bacteria to grow. Rhinosinusitis is 60% of the time bacterial, and because of the inflammation, the inability to drain, the bacteria can make biofilms, and that makes antibiotic therapy more difficult because they might kill what's in the purulent drainage, but the film itself will stick to the sinus cavity and will just kind of sit and hide in there. And once the antibiotics stop, they'll start to grow again. You can do intranasal lavage. Patients can also take decongestants. If they have antibiotics, they need to take all of them. They can take anti-inflammatory. It helps with the pain and also the inflammation. They might be given intranasal steroids. They can also do humidification, so they can have the warm humidity. They can sit in a bathroom with the shower going. They can do warm compresses, and sometimes that can help with the pain and also promote drainage. They need to avoid swimming, diving, and air travel because of the pressure. It's going to make it worse. Again, they should not be smoking. And they need to be aware if they take decongestants pretty regularly for an extended period of time, meaning more than just a couple of days sometimes, then they'll have temporary rebound congestion once they stop. They should sleep with their head a bit elevated. That will promote drainage. If they do have chronic rhinosinusitis, they can have surgical intervention, but again, that's done whenever the less invasive and non-invasive measures don't work anymore. And you really need to encourage the use of fluids to kind of thin out that mucus. Pharyngitis, that is a painful inflammation of the pharynx, and it peaks usually during winter and early spring. It is generally viral and can be caused by adenovirus, influenza, Epstein-Barr, or herpes simplex viruses. It can last as few as 3 days all the way up to 10 days. Generally, it is viral, but if it's bacterial, then penicillin is the drug of choice, and it's a shorter dose. It's usually 5 days. They can take analgesics for pain. You want them on a liquid or soft diet just because of the pain of the throat. Cool beverages usually work really well. Jello, puddings, things that are easy to swallow. You can tell them, warm tea, creamed soups sometimes, but warm, depending on your patient, might actually aggravate instead of help with the symptoms. Frozen items are also great as long as whenever they're swallowing them, they're smooth. So you don't want anything frozen with chunks in it. Popsicles are really good. Frozen yogurt, so those Go-Gurts that you can throw in the freezer, those are really good, and they also have some protein in them instead of just having a popsicle. They can put an ice collar around their neck. That helps. They can do saline rinses. You don't want them to do saltwater rinses because it'll cause more pain, but they can do saline rinses. Sometimes that will help. They still need to do mouth care because it can actually get worse, especially if it's an infection and they're not doing mouth care because, it causes more pain. So they need to be taught the importance of mouth care. Whenever they do have symptoms, they should not be sharing any kind of eating utensils. They shouldn't be sharing glasses. They shouldn't be sharing drinks, napkins, towels. If they have a phone in the home that everyone uses still instead of cell phones, they need to wash the phone in between uses. Obviously, coughing and sneezing into their upper arm. They shouldn't smoke, and they should have their toothbrush replaced because that can harbor the virus or the bacteria. If it's an irritant that's causing it, then you can help them identify the irritant, especially if it's chronic pharyngitis. It might be more due to an irritant that they're just not aware of. That way they can avoid the irritant. You can do warm saline gargles, again, just saline, not salt water. And the benefit depends on the heat. So if it really isn't that warm, you're not going to get as much benefit as you would if you had more hot. So it's supposed to be, the saline is supposed to be as hot as they can tolerate. So I think your book says 105 degrees, somewhere around 105 to 110 degrees, if they can tolerate that. And then irrigating the throat can reduce spasms, it can relax the muscles, and this can help relieve the soreness of the throat. As far as tonsillitis, sometimes tonsillitis and pharyngitis are confused. Their symptoms are very similar. They'll complain of a sore throat. They can have a fever. They might have snoring where they didn't have snoring before. They'll complain of painful swallowing or difficulty swallowing. They can have enlarged tonsils or enlarged adenoids. And if their adenoids are enlarged, then they will most likely be mouth breathers so that they can get more air in. They'll complain of an earache because the adenoids are swollen, closing off the eustachian tube so the drainage can't occur. You might notice ear drainage actually coming from their ear canal. They'll say that they have a head cold, they might get bronchitis, they'll have foul-smelling breath because of the infection. When you listen, they'll have noisy respirations, and their voice can be hoarse or just sound different. If it is viral, then you just do supportive care. If it's bacterial, penicillin, again, is the good choice of treatment. Analgesics can be given for pain. You want to increase their fluid intake, and you want them to do the saltwater gargles, not just the warm water gargles. You want them to actually do saltwater gargles because that helps to get rid of the infection and have them rest. Okay. If it is chronic, then they can remove the tonsils. They can also remove the adenoids. Fairly easy procedure in and of itself. Post-op, though, you have to really watch them. You need continuous observation of your patient because of the chance for post-op hemorrhage. Hemorrhage is a real potential complication for a tonsillectomy. Your patient will have increased pulse, they'll have a fever, they will be restless, they might be swallowing a lot more. Bleeding can occur up to 8 days after surgery, so once they are discharged home because they won't be in the hospital the whole 8 days, you need to make sure that they know what to report back to the physician. If they say that they feel drainage and they're swallowing a lot, if they're coughing up blood, obviously that's not good. They need to avoid vigorous toothbrushing. They need to avoid gargling because that can dislodge the clot. They need to avoid foods that are sharp or difficult to swallow. They need to take smaller bites because, again, that clot can be dislodged. They need to avoid anything really acidic because that can help to dissolve that clot, and then they can start bleeding again. Spicy foods, heavy lifting should also be avoided. They can use a cool mist vaporizer in their room at night, and that will help to keep the area nice and moist, and it promotes healing. They also need to take their full course of antibiotics even if they aren't feeling ill. Laryngitis is whenever they lose their voice or their voice becomes very, very faint. And a lot of it is the same treatment for pharyngitis, tonsillitis. Okay. Obstructive sleep apnea. They have to have a sleep study. And what they'll do is they'll have them actually come to a sleep study center, or there's an area of the hospital that will do sleep studies. And they're going to actually, they have you like bring your own pajamas and your own blanket. They'll have you bring your own pillow, anything that you normally do as far as bedtime routine. They want you to continue to follow that. And they'll monitor you while you sleep. So they will connect you to an EEG, an electrooculogram, and an EMG, and monitor. They might do ECG as well, or tele, to monitor your heart. And they're going to look at your sleep pattern. They will look at periods of sleep apnea, your snoring, your respiratory rate. And what you want them to do is avoid alcohol because that can suppress your system and they won't get a true reading of how you normally sleep. So they don't want you to drink alcohol. They don't want you to take sleeping pills or sedatives. They want it just on your normal breathing or your normal sleep pattern. Okay. Afterwards, they can give you CPAP or BiPAP. They can give you oxygen therapy. They also can do a tonsillectomy or remove the adenoids if they're enlarged and they think that that's causing part of the problem. If you have a deviated septum, they can go in and fix that. They can also do maxillomandibular surgery. This is generally the last choice, but if it's affecting your respiratory system, they can actually go and do reconstruction of your jawline. And sometimes that can help because they'll pull the mandible forward, which pulls the tongue forward. As far as epistasis, that's just a nosebleed. It's a fancy term for a nosebleed. So it's bleeding from the nose caused by a rupture of tiny distended vessels in the mucous membranes of the nose. Risk factors, any kind of current or recent infection, drying of the nasal mucosal membrane. So if they have oxygen that isn't humidified, then that can cause it. Nasal inhalation of corticosteroids, especially for an extended period of time, and then inhalation of illicit drugs. Generally, that's cocaine. I'm not too savvy on the latest and greatest, newest way to snort medications, but cocaine is generally one that causes a lot of nosebleeds. Trauma can cause a nosebleed, especially if you're hit in the nose. Hypertension, use of aspirin, and that's because it thins out your blood, and so your capillaries can pop and you have a greater chance of bleeding for a little bit longer. And then liver disease can also contribute to nosebleeds. If you do have a patient with a nosebleed, the first thing you want to do is pinch the soft portion of the nose for about 5 to 10 minutes, and your patients can usually do this themselves. If that doesn't work, then you can cauterize the bleed with silver nitrate or electrocautery. You can also give them phenylephrine spray, and that will cause vasoconstriction and help the area to clot and stop bleeding. Another option is gauze packing. A balloon inflated catheter is inserted into the nasal cavity for 3 to 4 days if it's something that they just can't stop. But usually the pressure will stop. If the pressure doesn't stop it, then cauterizing with silver nitrate will also be less invasive than doing the balloon or gauze packing. You can give antibiotic therapy if you need to or think that there's a chance of an infection. As far as nursing management, always think about your ABCs when you're taking care of any kind of respiratory, whether it's upper or lower. So make sure they have a patent airway. Make sure they're breathing, and if they are breathing, make sure it's sufficient. And then they should have good circulation. Check their pulse ox, check all their vital signs because it could be cardiac related. And then reduce their anxiety. If they're having trouble breathing in their upper airway, then the anxiety might cause them to hyperventilate. If they have a lot of bleeding from their nose, then it can drip down the back of their throat, and sometimes that'll freak them out and cause more anxiety. As far as patient education, obviously avoid nasal trauma. Don't get into fights. Make sure you protect your face. Don't pick your nose because they're going to have a clot and they might want to pick it because it feels weird. Try not to blow forcefully. If you have to blow, avoid spicy foods because that's going to cause nasal drainage. Obviously avoiding tobacco or smoking. And then you actually want them to avoid exercise. They can get up and they can walk around. But what they don't want is for them to be doing the deep, huffing and puffing that exercise can cause, and they don't want nasal flaring, anything to irritate that clot until it's healed. They should have adequate humidification, so if they are on oxygen, make sure it's humidified, and then they can have humidified air in their room. By just at home, they can get some kind of humidifier, and that will help keep the mucous membranes moist. We do have patients that have cancer of the larynx, and generally it's in the older population. It is more common in men than it is in women. And so initially they might just complain of what they do is they have like a partial obstruction, and as it goes from being more of an annoyance to more trouble with breathing. So they might just start to notice that there are voice changes. And then they start coughing because the air isn't passing through like it should, and it's starting to irritate the vocal cords. And then they can actually start having pain. Their voice will continue to change, and then you might actually see or feel a lump in the neck depending on how much they weigh. If you don't do anything about it or they don't seek medical treatment, then they'll have trouble swallowing. They will become short of breath, have difficulty breathing. That can lead to obstructions. It can turn into ulcerations because you're actually changing your cells within your throat. They'll have foul breath. So halitosis is something that can be noticed, and they just generally won't feel well. They'll start to get fatigued, tired, poor endurance, that sort of thing. Get a good history and physical. Doctor will take a laryngoscope, and he'll actually look at the larynx and see what's going on. They can do biopsies to figure out if it's malignant or not and how to treat. They can do a barium swallow test if the patient's having trouble swallowing. They can also get an endoscopy, CAT scan, PET scan, MRI to look and see what's going on. And, you know, the CT, MRI, and PET scan are obviously less invasive than doing an endoscopy or laryngoscope. And then if they can remove the tumor when they do the biopsy, they'll try to remove the entirety of the growth. Sometimes it's not possible because of how extensive the growth is. Then they will have to have a conversation with the patient and see, you know, this is kind of where you're at and here's the different options and consequences, complications, that sort of thing. Okay. If they do have laryngeal cancer, if it's earlier in the stages, they can do radiation. They can do the laser excision again because it's small enough. Or they could remove part of the larynx, just the part that has been affected. If not, and it's in the later stages, they'll do chemo as well as radiation. They'll remove the entire larynx, and the patient will most likely have to have a trach. And so they'll have a permanent tracheostomy, which is something that they have to consider. Okay. And this is just a picture of exactly what would have to happen if they had to remove the larynx. As far as you're concerned, get a health history, you know, do a holistic assessment, make sure they're taking in an adequate amount of nutrition. You'll look at their BMI. They'll have labs, so serum blood tests to check albumin, glucose, and electrolyte levels. You know, identify their health literacy level, especially since they're going to be getting informed consent and a lot of instruction. Do they have any hearing or vision impairments so that you have to alter how you communicate and educate, especially after surgery? And then make sure you start early on with coping skills, especially if they have to have the trach. And it'll be for the patient and the family as well. They're being diagnosed with something that they consider a horrible illness, which no one ever says, yay, I have cancer. But then they're getting a treatment that could be a life-saving treatment that also leaves them permanently disfigured. They're also going to be needing chemo and radiation and the side effects of those. And they're having to process this relatively all at the same time, like, you know, within days. So it's a lot to try and handle. As a nurse, you need to be in there and you need to be helping them. Complications of surgery, obviously respiratory distress because you're dealing with the respiratory system. There's always a potential for hemorrhage whenever you have surgery, so you need to watch for that. Watch for signs of infection. They could have breakdown. If it's partial at the wound site, if it's complete, you need to look at their stoma, the peristomal skin, and then the tracheostomy, make sure that everything's healing the way it should. Aspiration's always going to be a potential issue. They can also have tracheostomal stenosis, and that's just from hardening of the tissue itself. So it's not as flexible, so they can't expand whenever they breathe. It just pretty much